Today, you have Ozone Anesthesia has created very good platform for everyone. Thanks for it. And we are dealing with muscle relaxants in day and night, and we think that we have done everything right. But some problems are likely to occur in the recovery room, and they are very on a large extent. So the anesthesia practice was changed tremendously with the introduction of neuromuscular blocking agents by Griffith and Johnson in 1942. The neuromuscular blocking drugs have revolutionized certain surgical procedures and provided many advantages in the anesthesia practice as a part of balanced anesthesia. In our clinical practice, the administration, selection, and dosages of NM blocking drugs are usually individualized. Hello? Individualized by the anesthesiologist based on the patient parameters and the need of using it. But the concerns for residual neuromuscular block leading to adverse consequences have been reported in literature. The residual neuromuscular blockade is assessed clinically or using nerve stimulators. So today we are dealing with inadequate reversal from muscle relaxants. In short, we will look about neuromuscular transmission. The neuromuscular junction is associated with a motor unit consisting of a muscle and a nerve terminal. The place where stimulus is transferred from nerve to skeletal muscle is named as motor end plate. Acetylcholine stored in the mitochondria of nerve cells in the presynaptic vessels is released when stimulus is provided to the nerve, leading to opening of fast sodium channels and influx of calcium and leading to depolarization of the nerve membrane. The acetylcholine is released into the synaptic cleft and diffuses to postsynaptic membrane where the acetylcholine receptors are situated. It interacts with ACH receptors, causes depolarization of the muscle. Depolarization opens voltage gated calcium channels and allows calcium influx leading to excitation and contraction coupling. Acetylcholine dissociates from the receptor and repolarization of the membrane occurs as very quick within milliseconds. It is partly metabolized by acetylcholine esterases in the synaptic cleft and partly is taken up by the presynaptic terminal. Then in short about definitions, what is meant by motor unit? It is a combination of motor neuron, its axon, division of axons and the muscle fibers it innervates constitutes a motor neuron. Motor end plate, it is a small specialized area of muscle rich in acetylcholine receptors, and synapse area of nerve lying closest to the muscle cell situated opposite to the end plate. So this is the diagram of neuromuscular junction. The axon of motor neuron is being visible. It is having myelin sheath, nodes of Ranvier in between them, and there is a vesicles of acetylcholine in the situated in the nerve terminals. And when action potential is generated, calcium is required for accumulation of acetylcholine vesicles and its release. So after influx of calcium, acetylcholine receptors vesicles gather in one place and they are released, and then gets accumulated in the acetylcholine receptors which are situated in the postsynaptic membrane. So influx movement of ions, sodium, potassium and calcium are responsible for to generate the action potential and depolarization of the muscle fiber. The acetylcholine receptor, what is the structure in short? Acetylcholine molecule binds with nicotinic cholinergic receptors on a specialized portion of the muscle membrane, that is motor end plate. Each ACH receptor normally consists of 5 protein subunits, that is 2 alpha, 1 beta, 1 delta and 1 epsilon. And fetal receptors have gamma subunits instead of epsilon. And 2 alpha units are capable of binding acetylcholine molecule. When acetylcholine bind at 2 alpha units, then only opening of the channel occurs. And this is the structure of acetylcholine molecule receptor, and these are the ion channels. This is first one is ion channel, that is closed one, and the receptors are being visible and acetylcholine molecules are also seen. And after generation of action potential during depolarization of the muscle. Then sodium goes inside and calcium comes outside to generate the action potential and contraction of the muscle. That is the second one is open channel, and first one is the picture of closed channel, and above one is the arrangement of alpha, beta, delta subunits in the ACH receptors. So what is meant by depolarizing block and what it causes at the neuromuscular junction? They resemble the acetylcholine and readily bind to the ACH receptors. When we give succinylcholine, what happens at the NM junction? That is described here, generating muscle action potential, causing muscle contractions, and we can see in the form of fasciculations. Unlike acetylcholine, these drugs are not metabolized by acetylcholinesterase, but they are metabolized by pseudocholinesterases. Their concentration in synaptic cleft does not fall as rapidly as acetylcholine molecule, thus resulting in prolonged depolarization of the muscle end plate. End plate cannot repolarize as long as depolarizing muscle relaxant continues to bind to the acetylcholine receptor, that is phase 1 block. After some time, prolonged end plate depolarization can cause ionic and conformational changes in ACH receptors that result in phase 2 block. That is prolonged means exposure to depolarizing agent, that is 5 to 7 milligram per kg causes phase 2 block, and that resemble non-depolarizing block because the acetylcholine receptors at presynaptic junction and postsynaptic, they get exposed to the large amount of succinylcholine. That is also called as a desensitization block. The non-depolarizing block, that is, there is a competitive antagonist to the acetylcholine receptors because these neuromuscular relaxants prevent the action of agonists, that is acetylcholine on the receptors. They belong to the class of compounds known as antagonists at the muscles of acetylcholine receptors. That is a competitive antagonism, competitive block, that is non-depolarizing block, and mimicking acetylcholine block. Acetylcholine block is a depolarizing block, which mimics acetylcholine action. Then there are some terminologies, that is desensitization block. It is a part of phase 2 block. The acetylcholine receptors, as a result of its flexibility, is capable of existing in number of conformational change. Because the resting receptor is free of agonists, the channel is closed. What we have seen in the previous slides, when there are no acetylcholine molecules, the channel remains closed. When two molecules of agonist are bound to alpha subunit of receptor, it undergoes conformational change that opens the channel and allows ion to flow. That is the normal mechanism of neuromuscular transmission. Some receptors, even after binding with agonists, that is acetylcholine molecules, do not undergo conformational change and remain in desensitized stage. That is when large doses of succinylcholine are administered. And this can occur after administration of extra large amount of neostigmine also. That is a desensitization block. And channel block, it may account for local anesthetics, some antibiotics, tricyclic antidepressants, calcium channel blockers, closed channel block, and open channel block. These drugs prevent flow of sodium and calcium to their respective channels, and channel gets opened by acetylcholine and the drug molecule gets blocked in open channel blockade. Also the slender molecules, they can travel through, that of decamethonium, but some molecules which are larger, they get blocked into the open channel, thus preventing of flow of sodium and potassium and calcium, thus blocking the channel. The overall result is channel blockade. What we can see, observe in daily routine practice with local anesthetics along with muscle relaxants, antibiotics, that is aminoglycosides. And desensitization block is also seen with volatile anesthetic agents when they are used for prolonged period along with muscle relaxants. Then what are the neuromuscular blocking drugs? How they are classified? They are classified as, we all of us know, that depolarizing and non-depolarizing. Depolarizing are succinylcholine, D-tuberculorin, and non-depolarizing are steroid-containing nucleus. And mainly they are vecuronium, pancuronium, and rocuronium. And atracurium, cis-atracurium, they belong to benzyl isoquinoline group. Their way of metabolism is different. non-depolarizing blocking agent, they are metabolized mainly through liver and excreted to kidneys. But benzyl isoquinoline, they undergo Huffman's degradation and ester hydrolysis. They are independent of organ function. So reversal of neuromuscular blockade is done by anticholinesterase. That is what we routinely use is neostigmine, and recently introduced is a Sugammadex. In short, about Sugammadex, recommended reversal dose of neostigmine is 0.05 to 0.07 milligram per kg. I have mentioned here is microgram. So if a person is weighing of 50 kg, if we consider maximum 0.07 milligram per kg, it accounts to 3.5 milligram total. And it has, if you increase the dose, it has a definitely ceiling effect, and repeated administration results in side effects like desensitization block and exaggeration of non-depolarizing block. So it should not be increased beyond that limit. So ideal Sugammadex is now considered as an ideal reversal agent that fulfills almost all criteria of this ideal reversal agent. It is a alpha cyclodextrin, works by molecular encapsulation for reversing neuromuscular block. It has been found effective in vecuronium and rocuronium induced NM block. It is not capable of encapsulating isoquinoline or succinylcholine. Means it is not effective against atracurium and cisatracurium, but only when we have used VEC and rocuronium. The encapsulated complex is water soluble and is excreted unchanged via kidneys and may be delayed slightly in patients with renal disease. What is the recommended? It has been introduced recently by some Varennum Pharmaceuticals, Sugammadex, and its recommended dosage is 2 milligram per kg when T2 second stimulus has appeared in train of 4, and that is a moderate type of block. And 1.7 minutes in patients who have received 0.6 milligram per kg of rocuronium, because there are various intubating dosages of rocuronium that are being used, 0.6, 0.9, 1.2 like that, or in 2-3 minutes in 0.1 milligram per kg of vicuronium. Means for deeper blocks, dosages of 4 milligram per kg when train of 4 is 1 to 2 twitches. When there is no train of 4 and when the block is deeper means only 1 to 2 twitches of post-tetanic count. Then also Sugammadex reverses the block. It is not seen with neostigmine. For very deep intense block of rocuronium where largest dose of 1.2 milligram per kg has been used, we can use Sugammadex up to 16 milligram per kg and it is reversed within 3 minutes. On an average, reversal can be expected with Sugammadex in 2 to 2.7 minutes as compared to longer time that takes with neostigmine. And its use has been reported in neuromuscular disease as well. And in contrast to neostigmine, the effect is independent from the type and depth of anesthesia and temperature and acid base balance. Action of Sugammadex is not affected by all these means, and these advantages make it a unique reversal agent, and maybe it can become a boon in the management of patient with difficult airway. What we will see what is meant by safety margin. Neuromuscular transmission has a substantial margin of safety. Neuromuscular block only becomes evident when 70 to 80% of acetylcholine receptors at the NM junction are occupied by non-depolarizing neuromuscular blocking agents, and to produce complete block, 90 to 95 receptors must be occupied. So that is very safety margin for anesthesiologists. When 50 to 60%, it means that receptors are blocked, the muscle relaxant paralyzing effect is not evident. Only when they are occupied more than 70%, then only the effect is we can see. Then what are the concerns in clinical practice? The receptor occupancy is dependent on the plasma concentration of the drug. As the plasma concentration declines, spontaneous recovery occurs. That we all know. Attempt to reverse the blockade before receptor occupancy falls below 75% may result in inadequate reversal. The incomplete reversal may be identified in nerve stimulator. That is, train of 4 ratio is less than 0.1, 0.9 to 1. If it is less than T4 by T1, 4 responses appear in train of 4. If they are less than 0.9, then that leads to inadequate reversals in the recovery room. What are the clinical signs of inadequate reversal, that is loss of airway patency, and there will be definitely risk of aspiration, reduction of cough reflex, reduction of expansion of the rib cage, restlessness, there will be evident tracheal tug, decreased clearance from tracheobronchial secretion, and superficial ventilation can occur. And residual postoperative neuromuscular block causes decreased chemoreceptor sensitivity to hypoxia, and functional impairment of the pharyngeal and upper esophageal muscles impair ability to maintain open airway, that may lead to laryngospasm and increased risk of hypoxemic events as well as development of postoperative pulmonary complications. These are likely, PPCs are more likely to occur if NM blockers are being used in the intensive care unit. So we day and night we can observe these in signs and symptoms of inadequate muscle reversal. The factors which are affecting the neuromuscular junction, just I am mentioning the name, hypothermia, definitely metabolism of neuromuscular drugs is decreased, that will leading to prolonged elimination, and it will take time for reversal of the normal phenomenon. Then acid base disturbances, electrolyte disturbances, antibiotics, volatile agents, neuromuscular disorders, use of magnesium, and anticonvulsants that affect the muscular junction. In such cases, we have to use the make the use of NM blockers very cautiously. So we have to increase the interval between the aliquots of NM blockers. Now, how to avoid such prolongation? NM blocking agent must be used with caution in patients with underlying neuromuscular, hepatic, or renal disease or electrolyte imbalance. The larger volume of distribution in edematous renal patients, a reduced renal clearance, and decreased plasma protein binding can cause prolonged elimination. Liver disease also, uptake of drugs into the liver is decreased, thus plasma clearance is also decreased, leading to prolonged effect. Then what are the signs of neuromuscular recovery? All these signs are considered, some of the reliable signs are the assessment of reversal of neuromuscular blocking includes ability to sustain head lift for 5 seconds, sustained leg lift for more than 5 seconds, sustained hand grip for more than 5 seconds, maximum inspiratory pressure of more than 50 centimeters of water, ability to hold a tongue depressor between the teeth. These are considered almost some reliable signs. And some of the unreliable signs, what we observe clinically is protrusion of tongue, wide open eyes, obeying all verbal commands, cough reflex, normal tidal volume, and normal vital capacity. These are considered as some of the unreliable signs of neuromuscular recovery. Nerve stimulator, which has came into the practice in 1970, and it can predict reliable means of recovery. Means in prolonged procedures, in longer duration, in frail patient, we should definitely make an use of nerve stimulator. It is a non-invasive, has little risk, and can strongly improve patient's outcome. What is nerve? In short, about nerve, what we observe in nerve stimulator, that is, there are various responses that can be observed. That is single twitch response to be observed before administering the neuromuscular blocking agent. That is supramaximal stimulus are selected after giving sedation and before giving muscle relaxant, so that we can it is about the number comes about 45 to 50. And why this is taken, because under anesthesia we have to take maximal stimulus so that we can observe the responses. What we do in what is observed in train of 4. Train of 4 is most frequently used stimulation, and 4 supramaximal stimulation given every 0.5 seconds, and it is given after paralyzing the patient. And we can directly read from train of 4 response even though a preoperative value is lacking. It allows onset of neuromuscular block and moderate intense type of block, and also can measure recovery from neuromuscular blocking agent. We can see the responses 1, 2, 3, 4. Train of 4 between 0.2, 0.7 to 0.9 is associated with inadequate recovery. Before giving reversal, train of count must be 3. Unless we see 3 counts, reversal should not be tried at all. Then post-tetanic count. The post-tetanic count is, we can detect it is composed of tetanic stimulation of 50 hertz for 5 seconds, followed by 10 to 15 single twitches. That is post-tetanic count, means tetanic stimulation given for of intensity of 50 hertz for 5 seconds, and that is followed by 10 twitches, single twitches. So with this help of this PTC, we can it is used to detect deeper type of blocks. When some of the surgical procedures which require deeper blocks, the PTC count most of the time should be less than 3. And when TOF is not visible, if we can see the PTC in between 6 to 8, when count is between 6 to 8, then train of 4 starts to appear. Then third is tetanic stimulation. In this tetanic stimulation, high frequency delivery of electrical stimuli, 50 to 100 hertz, is given for 5 seconds. But its sensitivity is 70% and specificity is 50%, because it is also used to in the useful in post-operative recovery room, but it is very drawback is very painful. And because it has specificity of 50%, when even if you have not used neuromuscular junction and used volatile anesthetic agents, it will show fade on train of 4. So that is not most reliable technique, and it is definitely very painful. So that is not in use in the practice. Most commonly used is train of 4, PTC, and double burst stimulation. Double burst stimulation, it enables even a small degrees of neuromuscular block in the recovery room. It is considered as more accurate than train of 4. In this, it consists of 2 short bursts of tetanic stimulation and repeated by interval of 750 milliseconds. What is its clinical application? It was developed with specific aim of improving manual, tactile, or visual detection of residual non-depolarizing block under clinical conditions or during recovery or immediately after surgery. It is more accurate than train of 4 because fade is visible in double base simulation accurately. Onset and offset of block is faster in central muscles with a good blood supply. For example, larynx and pharynx. Peripheral muscles with relatively poor blood supply will have a slower onset, that is muscles of hand, and longer recovery time. Peripheral muscles of hand and legs. The muscles of airway and pharynx behave as central muscles at onset, means they get blocked early at the earliest. However, sensitive to neuromuscular agents and recovery is slow. So we have to see during recovery, we have to see that adequate cuff reflex is there, means muscles of airway and pharynx have recovered from neuromuscular blocking agents. That is, they are mirroring the peripheral muscles. This is the in short about neuromuscular blockade picture of comparing depolarizing, non-depolarizing block in neuromuscular blockade. This is the graph. The first graph is of tetany, then train of 4, depolarizing block, they are of equal heights, and non-depolarizing fade is seen in the train of 4 in when we have used non-depolarizing agent. That is ratio of T4 by Ta. It has to be more than 0.9 before reversal. Yes, reversal. And third one is double burst stimulation. Two stimuli of larger frequency are applied at separated by 750 milliseconds. Fade is seen in NDMA, and depolarizing, it is of equal height. Post-tetanic potentiation, that is last one, but it is very painful. And it is used to detect deeper type of blocks. And it is PTC is more useful, PTC and train of 4. Then how to resolve this crisis in our daily practice? The ultimate goal is to discharge the patient from operation theater with unimpaired muscle strength. Good evidence-based practice dictates that clinicians always quantitate the extent of neuromuscular block by objective monitoring, means by monitoring responses on train of 4 machine. Titrate neuromuscular blocking agents carefully so that no residual effect is manifested at the end of the surgery. Accelerate recovery by giving neostigmine at least 2 to 4 responses of train of 4 appear. And recently, the addition of Sugammadex helped us to restore neuromuscular function very nicely. We should initiate neuromuscular monitor when neuromuscular blocking agents are used, and specifically in patients who may show alter responses to drugs. Be cautious of various metabolic derangements that may have impact on neuromuscular transmissions. Means we are handling muscle relaxants routinely, but be cautious while using that and don't take it lightly. This is the take home message from this presentation. Thank you.